to just get going on that. All right. If we can close captions for those who want them, we will have them. So if you have questions, put them into the chat. Oh, exactly. If we have here some shortcuts, but if you have questions about getting closed captions, let us know.
Actually,
For hmm?
closed captions are not showing up as an option for me right now, so I don't know if I can turn them on.
Oh, we're having some tech
I just,
issues.
oh, I just turned it on, I believe.
Yeah, I think if you did, or I also clicked it, so hopefully
Let's
they're
hope they're
accessible
on.
now.
Okay.
All right, all right. Um, Wonderful. Upcoming seminars. So we did have back-to-back seminars this time around, but now we're going to go to the bi-monthly schedule. So we're going to be back in July with Amy Miracle and Lenny Jason to talk about the intersection really of RCCs and recovery housing, but we talk about the importance of recovery housing and building bridges to enhance recovery support. And then we have TBDs here for October and December, which is a good thing because we always kind of base the next kind of seminars that we're doing on what's currently happening and what the current questions are, the current issues. So by all means, send us your ideas. And if you have something to present, of course, you can reach out to us as well. All right, next slide. The steering committee who's been guiding this now past 6-year-long initiative is listed here. So you can reach out to any and all of us with ideas, questions, explore ideas, and so forth. Next slide. This is what we talked about a little while ago in our pre-meeting. Always a reminder for the Consortium on Addiction Recovery Science, if you want to engage in dialogue in a variety of ways on addiction recovery science, this is a great place to be. There are work groups. There's an online conference we do once a year. There's a number of initiatives we all collaborate on. This slide contains lots of links with upcoming meetings and opportunities that you will have in your email and online next week. Please look through it for things that might interest you and always reach out with questions if you have them. Next slide. One of those things that course does is the national conference I mentioned. The deadline is coming up. It's going to be online on September 23rd and 24th. And the submission deadline is coming up on May 25th. So keep that in mind. If you want to submit something, that deadline, you still have 2 weeks to do it. Next page. And then the other important thing that we always want to hear about is the list of RCCs, which we are maintaining. We currently have how many on this list?
275.
Cora, Liv? I'm sorry, what?
275.
Added a lot. Wonderful, which recently increased with the Kentucky RCCs you are hearing about today. So wonderful addition, and you'll hear a lot more information on that. If you know about more RCCs, we're always super grateful when you let us know. This helps other people find RCCs, people who want to refer to RCCs, people who want to partner with RCCs, also scientists who really want to partner with a local RCC to do science in this space. So if you let us know, we'd be super grateful. All right, that brings me to one of our highlights, but always a highlight for our series is the live feature for everybody to be grounded in what an RCC looks and feels like, and every RCC is different. So today we have Jadielle Wright with us, who's going to tell us what is going to happen when you walk through the door of her RCC. So Jadielle, want to take it away?
Yes, good afternoon, everyone. My name is Jadielle Wright, and I have the privilege of serving as the Assistant Director of the Recovery Division with Prevention Links. Today, I'm excited to talk to you about something that is truly close to my heart, my Rise Up Recovery Center in Roselle, New Jersey. Now, when people hear the word recovery center, sometimes they imagine a quiet office, a waiting room, or maybe just a place people go when things are falling apart. But Rise Up is so much more than that. Rise Up is a community, Rise Up is hope, Rise Up is a second chance, and honestly, Rise Up is my family. Every single day, people walk through our doors carrying different stories. Some come in looking for support in recovery. Some are struggling with isolation, mental health challenges, unemployment, grief, or simply just trying to figure out what's their next steps. Next steps in life looks like. And what they find is not judgment. They find connection. And at Rise Up, we believe recovery is not a one size fit all. Recovery can look like attending a support meeting. It can look like getting your first job after treatment. It can look like reconnecting with your children. And sometimes recovery looks like simply just getting out of bed and deciding to try again one more day. And the beautiful thing about our center is that people don't have to do it alone. We offer peer recovery support, wellness activities, community events, mutual aid meetings, volunteer opportunities, workforce support, and a safe space where people can just breathe and be themselves. One of my favorite things about Rise Up is seeing transformations happen in real time. We have participants come in nervous, quiet, and unsure of themselves. And months later, they're leading groups, they're mentoring other people and volunteering at events. They join our advisory board and even gaining employment in the recovery field. And I feel that that's powerful. That's what the recovery community centers are supposed to do. Remind people that they still have a purpose. And let me tell you something, there's nothing more inspiring than watching people who once struggle to survive begin to thrive. But we also know recovery isn't just about stopping substance use. Recovery is about rebuilding lives. It's about helping people find connection again and creating a space where people can laugh, heal, grow, and dream again. That's why Rise Up, you might walk in and see a smart recovery meeting happening in one room, a wellness workshop in another, someone working on a resume, volunteers setting up for community dinners, or peers just simply sitting together, talking and supporting one another. And yes, there's always coffee somewhere. And what makes Rise Up truly really special is that peer driven. Many of the people supporting others have lived experience themselves. They know what it feels like to struggle. They know what it means to rebuild. And because of that, they bring authenticity, compassion, and understanding that cannot be taught from a textbook. In recovery, representation matters. I believe hope matters, human connection matters. And often I say that recovery centers are not just changing individuals' lives, they are changing the entire community. Because when one person heals, family heals, neighborhood heals, and I feel communities heal. So whether someone is one day into recovery or 10 years into recovery, supporting a loved one, or simply just looking for connection, Rise Up Community Center, Recovery Center is there to say you matter, you belong, and your story is not over. So thank you for allowing me to share a little bit about the amazing work happening at the Recovery Center and the incredible people that makes it such a meaningful place every single day. Thank you, guys.
Awesome, Jadielle. And I love how you foreshadow already volunteers, which is going to come up to when our key presenters are presenting in the moment. And I can imagine that path, seeing that development, that's powerful. Beautiful. Thank you for setting us up perfectly for today's talk, Jadielle.
Thank you, guys.
All right, and hope to hear more as we go through the discussion parts of it. But wait, we just lost our polling slide. Oh, you're muted.
It's so that I can get the polling up on my.
Very good, very good. So we're going to do our usual polling questions just to kind of capture who's in the room and to foreshadow some of the content and get you guys thinking about what's coming next. So if you could take a moment to click through, as always, you click the boxes and you take the little gray bar on the side and pull it down to progress. And once you've completed all the items, the submit button will turn blue. And we're going to keep this running until we have about 80% of us completed it. How are we doing for percentage completed?
About 50%.
50%. We'll give it some more time. I saw Patrick, you just joined, so make sure you do the polling questions.
Oh, I did. You know me, I love data and I hate when people don't provide that data, so I don't want to be one of those people. And it's bad. Yeah, Bettina, sometimes it's like shopping surveys and stuff like that. I'm like, why do I spend so much time on this? They don't care.
Well, we do care about these data points if it's any consolation.
We're at basically 90%, so I'm going to go ahead and close.
Oh, look at that, Patrick. You patched it off. We've never been at 90% before. There you go. All right. So if you scroll down to the questions for today's talk, you can see them here. So first of all, the funny question, what do you think is the largest funding source for RCCs in Kentucky? Is it state, federal, or donation or others? And just over half of us think that it's probably the state funding that is the biggest source of funding for Kentucky's RCCs, and we will find out the answer in a few moments. Then we're always about partnership, but here we have some options about not just research partnership. If you're thinking about RCCs partnering with universities or other academic settings, what are some of the ways in which RCCs could do it? And we did have a lot of votes for research, which is amazing. We have speaking engagements. 86% of us see that would be a great way to partner. And then we have these other categories too. And those of you who wrote other, if you can put it into the chat, that would be awesome, because we want more options and more ideas. So this is some thought to keep in mind, and you will hear something along these lines in the upcoming presentation as well. So stay tuned. If you can get back our slides for just a minute left, because I want to introduce our speakers and our discussant. So you will hear from three presenters today. We have Martha Tillson, Amanda Fallin-Bennett, and Hartley Feld with us from the University of Kentucky, who are going to give their presentation on the RCCs in Kentucky. Right after their presentation, if you go to the next slide, we will have our discussant weigh in, Adam Viera from New York, from the Office of Addiction Services and Supports, to kind of like give his reflection on what it looks like in his state and what he thought about the data presented. And that's your opening call, as always, to jump in with your thoughts, questions, comments, ideas from anything you have heard. As always, open dialogue is what we strive for, because that's the point of coming together and doing things together. All right, with that, I'm going to turn it over to our wonderful presentation team.
Thank you. We are excited to be here. I'm going to request to share my slides. And while I'm doing that, I just want to say, Jadielle, it was so wonderful to hear about all the important work that you're doing at your RCC. And good morning or good afternoon, everyone, to those of us on the East Coast, and good morning to those of you who are elsewhere. Just one second. Okay, do you all see my slides?
Looks great.
Okay, thank you. All right, so I'm excited to be here with my co-presenters, Hartley and Martha. And before we get started, just want to acknowledge a few things. This study was funded by the University of Kentucky, a Markey Cancer Center Rapid Response Grant. The views that are expressed in this presentation are ours, and they do not represent official views of the University of Kentucky. And I need to share that I have a conflict of interest in this work, which is that I am a co-founder of Voices of Hope, which is one of Kentucky's recovery community centers. And so normally this is where we would provide all the background about how important and wonderful RCCs are, but we know that for this audience, we don't need to do that. So I'm going to jump straight into saying that the goal of our study was to showcase a Kentucky Academic Recovery Community Center Partnership Needs Assessment. And so although there has been some research describing RCC services nationwide, conducted by many of you here in this audience, there are no studies that we're aware of with a focus on Kentucky, which is a state with high rates of overdose deaths. And further, RCCs are rapidly opening across our state. And so Voices of Hope was the first RCC we opened in 2015 in Kentucky. And since that time, there's been really rapid proliferation that has really picked up recently. So there are now 31 RCCs in Kentucky, and this shows, where they're located. And really just to highlight how quickly this has happened, when we did our needs assessment, which was just in October to December, there have been some that have opened since then. So things are just really picking up in Kentucky. And so the aims of our study were to describe the basic RCC structures in Kentucky, staffing, services, as well as to evaluate RCC interest in partnering with researchers at the University of Kentucky on initiatives related to improving recovery capital. And some of this this has been something I've wanted to do for a long time, because as someone who's both a researcher and affiliated with an RCC, I get a lot of asks from other researchers at UK, like, could you connect me to, let's say, Voices of Hope? Do you think there's an RCC interested in partnering with us? And a lot of times what I was doing is just drawing on personal connections, but felt like there was really a need to try to put together a database of RCCs in Kentucky and like what they're interested in, so that we could more systematically match researchers with RCCs. And so I'm excited that we were able to finally do this. And then we're going to briefly describe two preliminary partnerships that have happened, after the needs assessment. So there are some RCCs in Kentucky that have long partnered with researchers, but through this work, we've been able to branch out and have had two preliminary partnerships just based on this. And so the University of Kentucky provided IRB approval before we launched. We had a directory of Kentucky RCC directors. And so we invited them all to complete an online survey or to forward it on to another decision maker. They received $50 as compensation for their time, and we had an 84% response rate. And these data were collected between October and December of 2025. So they're both very current, but also we've had new RCCs open. So it's evolving, and we're hoping that we can continue this assessment regularly. And with that, I'm going to turn it over to Martha.
All right, thanks so much, Amanda. I have the very fun job of actually getting to introduce the data to all of you. So I'm going to be focusing on the RCC structure, staffing, and services as reported by those decision makers who completed the surveys. We can go to the next slide. Perfect. Yes, data. So as a general description of Kentucky's RCCs, we can see that they have been open between 1 and 8 years with an average of 3.4 years in operation. Again, pretty large range in terms of overall operating budget between $150,000 to $1,500,000 with the average around $430K. And as far as the how the RCC was operating, we can see that the largest percentage was part of a larger nonprofit system, with 24% part of a community mental health center, 14% part of a health department, and only 5 of the RCCs, or 24%, were actually completely independent. So when we think about the sustainability of these RCCs, I just want to acknowledge that I think it's important that the majority of them were integrated as part of a larger system of services, which also I think speaks to that gap that we all know that RCCs are so important to be able to address. On the next slide, we can see the RCC funding sources. You will notice a very clear winner up at the top there. 76.2% of the RCCs that completed the survey were funded by state government, and this was really through CORE, which is the Kentucky Opioid Response Effort. For those of you who are not familiar, CORE is led by Kentucky's Department for Behavioral Health, Developmental, and Intellectual Disabilities within the Cabinet for Health and Family Services. So this is part of the state opioid response funding. The CORE is federally funded through these formula grants that are distributed by the Substance Abuse and Mental Health Services Administration, or SAMHSA. And these core funds are really used to support a wide spectrum of services. So from harm reduction, prevention, treatment, recovery housing, recovery community centers. And so we can really see from these data that a tremendous number of the RCCs are really being heavily supported by these core funds, with 71% reporting them as their largest funding source. But there's also a diversity in terms of funding. I was pleased to see that a third of the RCCs did report being supported through donations. Several RCCs are also receiving funding otherwise through federal government or through local city or county government, or also through partnership with the university for research. So in spite of the fact that there is an overwhelming reliance on the core funding at the moment, we can also see that RCCs do have a diversity of funding sources that they've been pursuing. On the next slide, we can see RCC staff and volunteers. So all of the RCCs reported having at least one paid full-time staff, which I think is very important. The numbers ranged pretty broadly between 1 to 22, with about an average of 5.2 full-time staff. And many of the RCCs also reported part-time staff as well, although this was less common. And we can see that for both full-time and part-time staff, RCCs reported a range of recovery coaches, drivers, and administrative staff, but usually recovery coaches are making up the bulk of that staffing. And then as far as volunteers, as Bettina was alluding to earlier, we can see that volunteers actually outnumber the staff, which is pretty wonderful. So on average, RCCs had about 10 active volunteers in terms of thinking about folks that are showing up at least a couple of times a month. But that ranges anywhere between 0 and 75, which is pretty tremendous in terms of thinking about the level of community engagement at these RCCs is really wonderful. But I think also for any of us that have spent time in RCCs, I think we're very cognizant of the fact that volunteers require full-time staff to manage, right? And so those volunteers cannot replace the full-time staff. And I think actually more volunteers necessitates more full-time staff in order to make sure that those volunteers are being organized and given meaningful opportunities to engage with the RCC. So I thought that that was very interesting as well. But very beneficial, of course, that these volunteers are contributing on average 13 hours a week, anywhere between 0 and 50 on a regular basis. On the next slide, we can see as far as what the decision makers reported for the populations that were served in their Kentucky RCCs. Again, tremendous variation in terms of the numbers of unique people served in a month and served over the past year, anywhere between 20 and 1,500 in a single month, with that average being about 250. And then as far as unique individuals over a year, the largest number was 18,000, but the minimum was 60, with an average of about 2,500 served in a year. But again, that range is really substantial, which when we think about, as Amanda mentioned, the difference in length of time that different RCCs have been operational, with some RCCs maybe being newer and building up their participant base, some being more well established, and then also thinking about that map of Kentucky. I know many of y'all may not be familiar with our local landscape here, but Kentucky does have a lot of really significantly rural areas. And that's one of the great things, is that we have seen a lot of rural communities investing in local RCCs, but important to acknowledge with these results that some of those smaller numbers may also be RCCs that are serving rural communities that may just have lower populations. As far as the demographics of the individual served, we can see that RCC decision makers reported that their participant base was predominantly male, although there was a wide range of percentages reported. And for the most part between the ages of 18 and 45, although it was nice again to see at least one RCC that reported 10% under the age of 18, or up to 15% over the age of 65, because we also know that these can be demographics that are much more difficult, much more challenging to reach in terms of recovery support. On the next slide, we can see, looking at the way that RCCs reported having specifically tailored their services. So the largest proportion, 11 or 12, had services that were tailored specifically for women, for folks who had recently been incarcerated, or for people who were unemployed. But on the other hand, there were many fewer RCCs, only 4 or 5, who reported having services tailored specifically for adolescents, for folks who identify as racial ethnic minorities, or for parents in recovery as well. But we can see, again, a large number of RCCs were still reporting tailored services for folks who are taking MOUD, people who currently use drugs, family members of people with substance use disorders. And so there's clearly being an investment and attention paid by these RCCs in terms of making sure that they do have services available for these unique populations, which have unique needs and require those unique supports. So thinking about the specific services required by the or provided by the RCC, 100% reported distribution of harm reduction or sexual health supplies. I want to celebrate that. 100% is amazing. That is really phenomenal. And we really, that was a wonderful finding to see. We also see 100% reporting outreach without a mobile unit. This could just be tabling in the community. And the vast majority of RCCs also reported recovery coaching, distribution of basic hygiene, mutual aid meetings, and life skills or personal development classes or workshops, as well as social events, which everybody in this room is familiar with RCCs. We know that a lot of these are pretty standard services and things that we would expect to see. The lowest percentage, as you can see there, only 38%, only 8 of the RCCs responding to the survey reported that they were doing outreach with a mobile unit. But again, thinking about the context of our RCCs here in Kentucky, not only with some of them maybe being newer, some of them having lower amounts of funding or a lower budget, and then also being in those rural areas where a mobile unit may be really important to be able to meet people where they're at, but people may also be more spread out and harder to find. So if we dig a little bit deeper into that 100% who reported the harm reduction or the sexual health supplies, we can see that a fewer number of RCCs were reporting syringe distribution or syringe exchange, which again, given our structure here in Kentucky, has to be done in partnership with the health department due to Senate Bill 192 implemented in 2015. That's just the model that our syringe service programs here in Kentucky have to follow. And then fewer RCCs as well reported distributing emergency contraception like Plan B. I know that has been a particular focus of Dr. Feld that she would love to talk to you folks about if anyone here is especially interested, as well as safer smoking kits. But that 100% that we saw on the last slide, we can see is really driven by naloxone, which again is wonderful to see, but also good to see that 20 out of the 21 RCCs reported distributing fentanyl test strips and many distributing xylazine test strips as well. All right, and then looking at health-related services for our last set of results for this section, a large number of RCCs, 81%, reported offering HIV or Hep C screening on site, but we can see that less than half of RCCs were offering the rest of the services listed up there as far as nutrition, reproductive health, smoking and tobacco cessation, which we'll be talking about more soon, and very few offering cancer screening. So when we compare that, for example, to the other types of recovery support services or harm reduction services that we were seeing on the previous slides, to me, this really stands out as some potential gaps in terms of RCC offerings. And when we're thinking about building recovery capital from a more holistic perspective, this definitely speaks to me as an area that RCCs could benefit from additional supports, potentially through university partnerships. So with that, I will pass it over to Dr. Feld, who's going to be talking about the RCC interest in partnering with researchers.
Hello, thanks for having us and kicking all of this off, Martha and Amanda. What's of interest here is that we wanted to know not only did they not offer if they had the services available, but also if they were interested in all of these things that, obviously could help improve recovery capital. As nurses, we are, innately interested in all of these health promotion things, and we wanted to make sure that this was something that also rang true for the community, and that they could prioritize it if they were interested. So we were excited to find that we have some opportunities in the state, that 66% have partnered with the university before. So we still have some that we'd like to reach that have never partnered with a university. The most common ways that they partnered is by hosting students. And then that second is by faculty invited to speak. And then the last way was that university researchers were contacted to help recruit for a study. And so we want to make sure as researchers in our state that I feel like we're getting a little bit of, we have a favorable relationship, I think, with our RCCs, which I was excited that these findings also showed, because we don't certainly want to make sure that we are partnering and that we're not doing anything that's exploitative, like we talked, like Martha mentioned, with the volunteer situation and hosting our students. It takes a lot of management within the organizations. Okay, next one. So interest in partnering specifically with the University of Kentucky to provide speakers for the courses to share about their lived experience upon faculty request. We were so excited this was such a high number, because we've done this before with some of our local partners in Lexington, and the students' evaluations of this, particularly our nursing students, blew us away. They were really impressed, and it really helped reduce stigma. It helped improve empathy. And I just think that this is so needed, especially for trainees. So we were excited about that number. And then working with students to complete internships, they were also interested in perhaps hosting students, receiving training from peer staff, or for peer staff, and then research related to substance use and recovery. So those were all pretty popular. So we were excited that we, have some potential partnerships here. And all of these are sort of the caveat of, like, if we had funding. So at least this part, we don't need funding for, right? We can usually do a lot of this just in our academic roles. So some of the next ideas and interests that we have, we will be seeking funding. So if funding were available. They are most interested in nutrition, violence prevention and safety, reproductive health, all topped the topic areas of things that they're interested in implementing. We think they do have a little bit more education already happening in Hep C and HIV screening. We were excited to see the smoking and tobacco cessation number was high-ish. Considering that is one of our initiatives and funding mechanisms for this. And I think wound care, again, they've received some, but probably could use more. And perinatal health, we were a little surprised that this number was a little lower, but we're excited that at least on the reproductive health side that was still an interest. Okay, and then again, if funding were available, hosting education sessions related to cancer screening, hosting a mobile mammography unit. These were overwhelmingly supportive, and then distributing free at-home cervical cancer screening. We have a pretty active cancer center, and we really haven't tapped into some of their resources. So and funding in particular, as some of other funding sources dry up, that this is a really nice area that there is a need and interest. And so we look forward to future interventions related to this. Next slide. Okay. Oh, sorry. I thought there was some more. So I was going to kick you off by saying where we're heading with this, with the tobacco piece, and Dr. Fallin-Bennett is going to continue that work. So thank you so much.
Thank you, Dr. Feld and Dr. Tillson. And so to finish off, we're just going to talk about some preliminary partnerships that formed after this needs assessment. And so, as I mentioned before, the University of Kentucky has had extensive partnerships with some RCCs. So this is not the extent of all partnerships, but rather something that happened from this needs assessment. And so I will say that some of these partnerships, as Dr. Feld alluded to with universities, don't require a lot of funding. Most things require some funding, but I will say, this is a tiny, tiny grant from the Cancer Center to do this needs assessment. And then we have, at the College of Nursing, we have a tobacco treatment specialist asynchronous training course where you can participate, and it takes about 27 hours, and you can become a certified tobacco treatment specialist. And so I had asked around to some recovery community centers before we proposed this, would your staff be interested? Because I thought I might get a no way, but a lot of people said we would love the opportunity for professional development. This is an important issue. So when we asked in the needs assessment, we came up with 12 of the RCCs indicating an interest in partnering with UK to provide tobacco treatment services. And interestingly enough, we got comments from some of the people saying no, was that the reason why is because they already partner with the health department to provide tobacco treatment. So really it was received very positively. But after we started with the funding from the Markey Cancer Center, our local American Cancer Society also reached out and just asked, do you have any ideas for professional development? So we were able to add a little bit of their funding in as well to fund 5 scholarships for RCC staff members to become certified tobacco treatment specialists. So during our needs assessment, we notified directors of this opportunity. We invited them to forward an application to their staff. And we were able to fund 5 of the 7 interested applicants to begin this training. And so we just wanted to show you some excerpts from the scholarship application. So these are from RCC staff, where we were asking them, like, why would they be interested? What would they do with it? And someone said, ultimately, this certification will allow me to provide a higher standard of care. It will ensure that I am not just helping people survive their addictions, but giving them specialized tools to accomplish a level of physical and mental wellness that many never thought possible. And another person said, obtaining my certification as a tobacco treatment specialist would significantly contribute to my professional development by expanding my knowledge, skills, and ability to provide more comprehensive care to the individuals I serve. In my current role at a recovery community center, I work closely with individuals who are overcoming substance use disorders, and tobacco use is extremely common. Gaining specialized training in tobacco treatment would allow me to better address this often overlooked area of recovery. And so we are just kicking this part off. So we just notified the individuals who've received them, and they've started registering. So we can update you on how that goes at a later time. And then just as another example of ways that I think sometimes happy accidents happen at universities where we can connect with RCCs, I happen to be in a leadership development program with our local cancer center, and we had to do a leadership project, again with no budget, but nearly all the RCC directors, so that was sort of what prompted all those additional questions about, would you want to see a mobile mammography unit, take-home cervical cancer screen? And I was just shocked that nearly all the directors said yes. So it was in the 80% that wanted to have educational sessions. Nearly all of them said they wanted things like a mobile mammography unit. And in fact, one of the ones who said no, their rationale was they didn't have a parking lot. So for the most part, there was a great deal of interest. And so Markey Cancer Center has an outreach arm called the Kentucky Cancer Program, where they actually go and do educational sessions with partners out in the community. And so through this leadership project with no funding, I was able to work with Kentucky Cancer Program and to see if we could tailor some of the materials that they would normally deliver on to add in the link between substance use disorder and cancer. But they have standard materials they deliver on the 4 screenable cancers. They already have a searchable database, ways to link participants to cancer screening. So we are going to go and train the RCC staff at one RCC. And then we are also going to then host a community session open to the general public at that RCC later this month to train them on these issues. So as Dr. Feld mentioned, hopefully this will lead to additional partnerships. The Kentucky Cancer Program was not aware of the network of recovery community centers before this, and so I'm really hoping that this will just be the first of these types of initiatives. And so we wanted to pose a discussion question to you all, and then I'll stop sharing my slides. We think about this a lot, so we were hoping that some of you all might have input on how a university and an RCC can design a partnership that respects lived experience as equal to academic experience, shares decision-making power. What concrete structures do you think are needed to balance this in practice? And what are your thoughts? Because as Dr. Feld said, we just always want to be really cognizant that we're approaching this in the best way we can.
This was fantastic. So much food for thought, so much great data. I really appreciate it. I'm torn now by just letting Adam weigh in first with his thoughts, or really diving into your discussion point first. Which one should we do? What do you guys think? Dive in first to this question, Adam, or start with your comments first?
I'd be happy to dive into that question first. I think it's such an important question and something that I've been discussing even earlier this week. So really curious about what other folks think about it.
All right, let's dive right in. So how can you make these partnerships? And by the way, I love how many different ways you guys all identified for how there can be this partnership between RCCs and their academic partners, and that you asked directly about it, and how much buy-in you got. It's wonderful. It's a great blueprint for others to follow. It's impressive. What do you all think in the room? What are the things to make these partnerships, what's needed to make these be equal, power sharing, empowering relationships? So I kick us off with some views for myself, but again, I'm also really wanting to hear from the room. For us, like we have a grant on which we have co-investigators who are at RCCs, and their percent effort is protected. Their percent effort is paid by the grant. And I think it's really important. There are so many decision points, discussions. There's time you invest as you develop something, even when it's small, but in order to make it grow into something big, you have to invest time and effort to think things through. And I think the time needs to be protected, needs to be funded to engage in that. So having space and budgets to protect the time of the people who are giving you the feedback, I think is incredibly important. What do others think?
I'll jump in real quick. I can't stand silence, Bettina.
Gotcha.
And I put the link in the chat. You guys know I'm a big proponent for community-based participatory research. But that's I would say also in addition to the partnership, I know it's like extra work, right? But kind of what Bettina was talking about in the presentation, great presentation, amazing work, y'all, by the way. And I would say the reason I say in addition to the partnership, because I think that it sounds like what you were talking about is kind of co-PI ship kind of partnership, right? And I think that that's an amazing step, right? That type of community, like we're both doing this thing fully together. But I do think that community-based participatory research, like the principles still apply. Um, and particularly like in that partnership pulling together, because I'll say like, my issue and one reason I bought into CBPR, and I didn't come into the field really, it's like I'm a quantitative guy. Give me a whole bunch of data and I want to run some stats and, get some empirical answers and that kind of stuff. But like I'm just one person, and we rely on the peer review system as scientists. Like I put in a manuscript and a bunch of people who are smarter than me read it over and pick it apart and tell me what an awful researcher I am, and then I try and fix that. And but the thing is just I just can't know everything, so I need help. And how do I get that help? And even with that sort of partnership, right? Like how do we create that sort of peer group in a way that is like you have all these different voices at the table in partnership trying to sort of push forward. I think CBPR is definitely one way in, but some type of community engaged strategy that includes that sort of partnership as far as co-PI, but then also like how do you bring different voices to the table? And we all know those that end up being missing is not just, people with lived experience, but people with living experience. We end up missing that kind of stuff. So sort of a broad reaching community engaged effort. And I don't know though, I say that and I'm just like, man, this is just putting a ton of work on people's plate. Like CBPR is hard, you guys. Like it takes time, it takes effort. And you were talking about, the level of funding that we actually get to do these things and the time and the resources we have. But, take a look. It's a shameless plug still for the toolkit that we put together. There's a spectrum there, right? And it's not so much like going all the way over to full CBPR methods, but like how can we incorporate some of these principles into these efforts in a way that sort of brings in the rich set of voices that can really contribute.
Thank you for sharing those thoughts, Patrick. Excellent. I'll join you in a shameless plug. Ellie, if you can put our seminar on there, which talks about the same continuum and has examples from a field about how these partnerships develop and what they look like. I was also going to ask you guys, Amanda, Martha, and Hartley, you've done this partnership work. What are your recommendations to us of like best practices and values?
it's hard. I feel, it's one of those things that's a little intimidating for this group because I'm like, we were hoping to learn from you all about best practices, but I guess this is also a shameless plug, but I personally think that when it comes to like the power differentials between researchers and community partners, that I think there's a lot to be said for partnering with recovery community centers and to work to employ people at the recovery community center to deliver interventions. And so that's a model that we've used in the past. And I feel like some of the things that it helps with are that it, unlike in maybe some other kinds of spaces, like if you wanted to hire a peer and place one peer in a hospital setting or one person in a clinic, there's a lot of potential that they might be the only person with lived experience, or, there might be power differentials. So the RCC staff can help look out for the individuals who are working with the research team. There's room for upward mobility in recovery community centers, which is maybe different than on some research teams. And so something that I guess we have found that as a quote unquote best practice is partnering with RCCs to support their staff versus trying to hire someone to be temporarily on our team at the university, that there's so many more opportunities for professional development, and then so many opportunities for the staff and leadership at the Recovery Community Center to weigh in from the beginning on how they'd like the intervention to look. It can provide some financial benefit to the Recovery Community Center. But again, I sort of hate to speak on best practices because I feel like I'm always thinking about this question and always learning and always feeling like I don't have a great answer. So I'm open to hear someone else's thoughts.
Yeah, thank you for sharing your thought as we are posing this question. Jadielle.
Yes, so like my thoughts were, so for our recovery center, the collaborations that we've already done with universities are usually on a level of like, for volunteers or internships, like we've utilized college students to come and learn and get that hands-on experience within our recovery center, which I think is really amazing for them to just come and see, because sometimes seeing is believing, being part of it is where you really get that understanding. I'm not a person in recovery, I'm an ally. And, in my personal experience, I've had family members that had substance use history, but I feel like when I became a social worker and started working in the actual field is when I really was able to put the pieces together and kind of see how research, how the schooling, how my education really came together. I think it would be cool if sort of like if universities and recovery centers could just like collaborate more on just having that understanding of lived experience and how it can be applied to research and how it can help guide, the research that is needed to produce more funding, to produce, better systems of care and policies and things like that. I think sometimes it helps to have the real data. I could talk here and say, we need this or we that and that, but unless I have the data or the research or something to kind of back me up, sometimes like my efforts and my advocacy is just not heard. And I feel like if, we could have more of those partnerships, we could really see more effective change. We can have people that don't understand the stigma, understand more, because sometimes some people need to see it, they need to see it on paper. They need to see that others have experienced it other than just Joe talking about his one experience. Like they want to know, is there more than just Joe? So I think it would be really nice to see more of that collaboration within the recovery community. So, yeah.
Awesome. Thank you, Jadielle, for sharing that. And we have Martha and Joe.
Yeah, I love how you put that, Jadielle. I completely second everything that you said. And I think especially reflecting on the impact that it has on, for example, students and interns coming into RCCs. I've definitely seen that. So like I'm a person in recovery. So I feel like I walk into an RCC and I'm like, I am at home here. These are my people. But, I recognize that's also not the case for a lot of other folks who, maybe don't have that personal or familial lived experience. This is a new space for them. But as they get to know it and as they get to know the participants and they get to know the staff, and it really, I think, opens their eyes to the value of the RCCs in general, but also the expertise of the people in the RCCs in a way that you can't just explain that to somebody. You can't just show them the numbers on the page. Like, right, being there, I think, is really so impactful that way. And I think to Amanda's point earlier in thinking about how do we work around these power differentials in terms of these partnerships between researchers? I think researchers making the time, like the PIs of the grants and the people who are leading these research efforts, for them to also make the time to come into the RCC, to get to know what it looks like, to get to know the staff that work there, especially if they can be showing up in a capacity that is not just related to the grant, that is not just related to the university partnership, just showing up to a community event or like volunteering at the Recovery Awareness or Overdose Awareness Day. I think that can go a really long way in terms of really demonstrating humility, because I think as much as a lot of university folks and professors and PIs and researchers, I think, are very humble people, like there can be an assumption of that power differential by people who aren't in those academic spaces, to where like I can be the most humble person in the world, but when I introduce myself as Dr. Martha Tillson, like research assistant professor at the College of Medicine, all of a sudden I'm getting a different response than when I say, hi, I'm Martha, I'm a person in recovery. So I think thinking about those power differentials and those partnerships, I think just wanted to really highlight again the importance of being in those spaces and taking the time to get to know those spaces in an authentic way.
Perfect points. Thank you, Martha. Joe.
Since my name was mentioned, I figured out it was perfect to chime on, chime on in, since my name is Joe and I'm one person. No, I keep observing this from a lot of different angles, and what I was really thinking is a few things. One, RCCs pride themselves on being non-clinical, yet we want to get data and think of interventions and do a lot of clinical-like stuff and the things that we're talking about. So I was wondering about that, the nuances there a little bit. But with that said, um, and I've presented at RCCs before and science presentations, and what I've observed is that RCC attendees really want to know more about science, and that's across the board. And so, what's interesting to them is I think they want to know how science is done and like how they can contribute. So it's a little bit along the lines of echoing what Dr. Tillson was saying in terms of spending time in the RCCs to get to know them. So ways to create those that linkages or those connections, and students might be a good, not to propose the solution, but students might be a really good way to do that, because students are kind of learning how experimental design is being done themselves. There's a natural synergy there in terms of data that was presented today, but also going a little classic, like kind of classic recovery a little bit on this. A lot of mutual support meetings are still a big engagement at RCCs. So I like the idea of a campaign. My wild thought is that science is spiritual. We're both after the truth. We're both seeking truth in our endeavors. And sometimes there's not knowing how the data relates to them in a meaningful way. But I've always seen curiosity at RCCs and in the attendees that they want to know more, and how science is done is interesting to them. So my
Yeah.
thoughts.
Thanks, Joe. That's excellent. Hartley?
Hey, I just want to piggyback on all of that. The two of the things that we do at UK, and not that we have the answers, and this is more of like, trying to give Dr. Fallin-Bennett kind of credit for some of these things that she works on that really integrates both faculty and students and people with lived experience, is we have there are two things: the Survivors Union of the Bluegrass, which is where researchers come to present, and I think you've presented on that here before. But it's a really amazing experience for both the researchers and people with lived and living experience to weigh in on where we're heading and how, and for us to change up what we're doing, because it really gives voice to the things that we don't know. But also, the other thing that's been really rewarding for me to see is a lot of our partners, especially from Voices of Hope, our largest RCC locally, they come to present at our substance use research event at the university, and so and they have a whole carve out now, and Dr. Osler is on here, and she's a member of that team, but they really focus on this community and peer-led lived experience piece that is kind of remarkable, and it's great because they're competing against each other for some prize, like a reward or a award at the end, and they take it really seriously. We work with them to help them do the posters and provide data of things that they've been participants of on some levels, but then they get to be the person who's presenting the outcomes. And then they stay and go to all of these neurology things. Joe, to your point, like they really want to know the brain chemistry behind it. Like they are all in on some of the molecular stuff that I get lost in. And they are just really excited to be learners for the rest of the event. So they present their posters and then they stay and are learners for the rest. And I think it's a really unique opportunity that I hope more universities do, and make it free and parking available and walk people through how to get there, because we're intimidating. We're a huge university. So thanks.
Yeah, the logistics are so important. I'm glad you highlighted that too. Susanna, and then we'll go back to Adam to actually do his overview of reaction to the rest of the discussion, and we can go back into this topic. Go ahead, Susanna.
Yeah, I heard a really inspiring example from people who had difficulties recruiting people with HIV into treatment studies, and they had nurses who gave talks at all the places where they had people meet organically to talk about living with HIV and whatnot. And they oftentimes found that they got to give their scientific talk, which for dissemination would be really great. If we do research in this space, wouldn't we want to disseminate it to the people who have questions about it, who say, oh, where is this going next? What do you find? How does any of our data work? But then also to just be available to then answer questions where they say, so I've heard this and this. Can you what do you know about it? Is that working? Is that not? Can you find out? And then because they came back more for future sessions, they said, I don't know anything about that, but by next time I will ask my colleagues and look that up, and then I will have, and so people made really close relationships. So it helped the researchers for recruitment and disseminating their results, but they also became familiar to the people that they were trying to help. And so they said like, oh, I know Joanne, she's the nurse who does this and this, and so they were trusted academics that could then also answer questions for them, find out more stuff, and answer all the curiosity questions that you brought up, because I think those are excellent signs that people are curious. They want that involvement. They say, tell us more, and to just be available and be people in the RCC space, and which is why I'm also thinking it's really important for researchers to go to the RCC space and just introduce themselves with their first name and say, here's the science, and I'm explaining it briefly so that you can also ask questions after and have feedback. And it's like, have you ever considered? And we're like, oh no, we never even asked about that. Geez, this is great. I will put that in my next research project or something like that.
Wonderful, which very much relates to both Joe's comment on curiosity and Martha about authentically showing up to just be part of it and contributing to what the center does. Adam, we are going to be beyond the hour, but we'll keep this official part of a recording. So whatever you're going to say will still be in our recording that we'll put live. What are your gut reactions to the whole presentation?
Oh man, this is quite a tough act to follow because I have so many thoughts. It's been such a rich discussion and a fantastic presentation. Just thank you to the folks from University of Kentucky for presenting. Definitely a lot of ideas about some of the work that we are trying to do at OASAS here in New York State. And we have a commissioner right now who has a research background and has really emphasized research evaluation, just building the evidence base for all of the services that we oversee. And so certainly within the recovery division and Viera, we are emphasizing, building some more evidence around the effect that the recovery centers and all of the other recovery support services that we support statewide are having in the state. And so, I think just to kind of reflect a little bit on the presentation, but also to selfishly maybe respond a little bit to the question, one of the things we're really trying to do is to build data and research literacy amongst the recovery centers that we fund. We call them RCOCs, Recovery Community and Outreach Centers. So just if I switch into that language, you'll be aware of that. But really trying to make sure that we share back the results that they are giving us. Once we've had a chance to clean the data and aggregate it, we give them a sense of, this is what we're seeing, and this is like the interesting insights that we've gleaned from it. What do you think about this? Does it look accurate? Are things surprising? So trying to build that literacy and that ability to communicate around the research is something that we're really focused on, as well as trying to build capacity in sort of other more tangible ways. So having a little bit of an investment in technology, knowing that so much of the data collection analysis involves having hot broadband internet. And, New York, it's easy to forget, has quite a lot of rural counties. I think a lot of folks focus on New York City, where I'm based, as a major urban center, and there are a lot of other urban centers throughout the state. But we also have large swaths of the state that are rural. And so wanting to make sure that we have an investment in those areas and also an understanding of how they differ. So I did want to just kind of comment on that. And I think a big part of, building evaluation capacity, research capacity, data literacy involves recognizing and respecting that there are different and diverse ways of knowing and understanding the world, and that all of those are valid and valued. And so moving away from just kind of quantitative to like more qualitative and even beyond ways of, building evidence and thinking about practice-based evidence as well as evidence-based practices. So that's kind of my reflection more to that question. But I did want to talk a little bit about, some of the ideas we're having that I think resonate, because we are trying to have more involvement of evaluators and academic partnerships in the work that our recovery centers are doing, which I think has involved a lot of mutual mentorship, support, communication, and capacity building. I'm really excited to say, having our evaluation team members visit the recovery centers to be able to see firsthand. And I say recovery centers plural because we know that when you visit a recovery center, you've seen one recovery center and everyone is different. And so trying to give them as much of a sense of the diversity of the recovery centers as they are able to see is a big part of what we're trying to focus on. Not just, okay, you visited the one local one, that's great, but let's have you visit several so you can see how they vary in terms of staffing, structure, services offered, who they're serving, where they are in the community, and how they interact with the community. So that's really important to us, as well as building in the role of our LEAP, our Lived Experience Advisory Panel, to be able to be involved in any of the work that we're doing around research and evaluation. And finally, an investment in workforce development. So we have a number of scholarships for folks, including supporting individuals who want to become peers, to get their certification, or to continue with some of the other certifications that we offer, as well as a leadership institute to build leadership for folks who maybe have already secured the education and the certification, but want to build their expertise in other ways. We are really excited about the work that we're doing to, again, build that infrastructure to do more research and evaluation with the recovery centers, because we have a number of activities we're engaged in that are similar to what University of Kentucky folks presented. So I was feverishly taking notes about some of the things I'm hoping we're going to do, because one of the things we've been looking at is getting a better understanding of the ecosystem of the state when it comes to recovery support services. We fund 31 recovery centers throughout the state, but we know that there's an equal, perhaps larger number of recovery centers that aren't funded through the state. So we want to kind of also understand, what are they doing? Where are they located? How could they expand the reach of the services that we're doing, which is the other piece we're looking into. What is our goal for what we want to see in terms of recovery centers in the state? Do we want one in every county? Do we want to have them distributed based on population or need? Do we want to have it be based on travel time? So maybe it's about situating them in a way that reflects the travel time that folks would be engaging in to access the nearest recovery center. So these are all questions we have. And then just also closing on the idea of metrics of success. What is it that we want to say, because we want to collect data on what the recovery centers are accomplishing, because using that data, we can then support additional planning and investment in those services. So being able to show that, but also to look at who are we not reaching, or what are we not accomplishing, and why, so that we could do a better job next time around. I think that quality improvement is so critical. And so just to kind of close this out, I did want to kind of acknowledge that this isn't new in terms of what we've been doing. It is an expansion of what we've been doing, and that we've been using some of what we learned, similar to what the University of Kentucky folks shared around who is being served and who isn't, and then having investments in supporting the recovery centers to reach the communities that may not be. So we noticed similarly low rates of attendance and engagement amongst young people. And so, consistent with our governor's state of the state priorities, we are investing in an expansion for youth services in about half of the recovery centers. So that's going to be that's actually a competitive funding opportunity that's out right now for folks to be able to identify, what are the ways in which they're going to expand tailored services to adolescents and young adults. And we've done similar work to expand services related to gambling and gambling recovery. How are we meeting the needs of those individuals, particularly as New York institutes 3 new casinos? So certainly something that we're kind of paying attention to, and again, aligned with our governor's priorities. How do we make sure that the services are delivered in a trauma-informed way by making sure all recovery center staff are trained in trauma-informed de-escalation and conflict resolution approaches, and thinking about the role of peers. And so we're doing a lot of work to assess what peers are doing, where are they located, what kind of different institutions have they been integrated into. We have peers in emergency rooms and other clinical locations, but also within lots of criminal legal settings like overdose intervention courts, jails, and prisons. So we want to make sure that we're kind of remembering the role that they play to kind of bridge people from other service settings into the recovery centers, and how that can kind of be enhanced. So I could keep talking on this, but I know that we're already out of time. So just want to thank you for the opportunity.
That's perfect. Thank you, Adam. So a couple folks had to jump off already because we're at 1 o'clock or past 1 o'clock, but they all expressed their appreciation for all of you speakers, which I also have. This is that we will stop the video for the online version, but we'll keep recording so we can take notes, and then whatever links, ideas, thoughts we have that might be shareable, we'll put into our written notes after this meeting. And